not the least as described in the definition of pain as an unpleasant sensory and emotional experience, right? And in the larger picture, how about emotional processes and pain? And I will highlight some perspectives. First, pain does not automatically lead to disability. Not all people are equally affected by their pain problems. But it's well known that emotional processes are risk factors for the development of pain chronicity and pain-related disability. We also know that there is a large comorbidity between pain and mental ill health, such as depression and anxiety disorders. And altogether, there might be a large impact on daily life for these patients with both pain and emotional problems. And these conditions are also the most common causes for long-term sick leave. And finally, living with pain might evoke a lot of different emotions. The stories of people living with chronic pain reveals struggles with identity. Who am I when I no longer can do the things I did before? Feelings of loss and grief, but also feelings of uncertainty, struggling, and an impact on social relationships. How and when to disclose my pain problems and not, etc. So how to cope living with pain. So to set the stage for today's talk, I would like us to keep in mind, and these are the things I will touch upon, how can we understand, intertwine emotion and pain processes? And could emotions be targets of treatment for patients with chronic pain, and in which ways? And not the least, can we think of improved treatments for patients with comorbid chronic pain and depression and anxiety? So first, like what is the problem here? What's the clinical picture? And clinically significant, we know that significant emotional problems are common among individuals with chronic pain. And for this presentation, I will use the term emotional problems or negative emotion to denote sadness, anxiety, low mood, anger, because these feeling states often co-occur. Low mood, depression, and emotional distress that lead to functional problems are common. But it's also the case that maybe not all patients are aware of or choose to include their emotional difficulties in their problem presentation when they seek healthcare. And many times they are not asked about them either. But as said, we know that there is a marked co-occurrence between chronic pain and emotional problems. And in the general population, it has been found that the prevalence of depression and anxiety disorders was 7% among those without pain and 15% among those with chronic pain. And that chronic pain was similarly associated with depression and anxiety disorders in developed and developing countries. Another example, among individuals sick listed for chronic low back pain, 31% fulfilled criteria for at least one current psychiatric disorder. And we also know that the presence of emotional problems makes for a more complex clinical picture. So what does the clinical picture look like? This is a study from the Swedish Quality Registry for Pain Rehabilitation. This specific study included more than 22,000 chronic pain patients. And the question here was, what were the clinical profiles? And results show that patients with chronic pain refer to these specialist clinics. They are not homogeneous in their clinical presentations. Rather, 3 different clusters could be identified. Cluster 1, which is the one I'm focusing on here, it was 39% of the participants. They had a profile with clinical levels of depressive and anxiety symptoms, low activity engagement, and overall associated with a much higher burden, more pain, lower function, lower quality of life, and also demographics are related. In this study, for example, lower educational level, higher proportion of patients born outside of Europe. And these patients with the most severe clinical presentation, what is important to know, and what we learned from this study, was that they showed significant improvements. So they also improved from their rehabilitation. However, even though this group of patients improve, still after rehabilitation they show high levels of problem, partly because they start from high levels. Another example from pain rehabilitation is a systematic review evaluating prognostic factors for beneficial outcomes after multidisciplinary pain rehabilitation. So who improves and who doesn't? It was found that, in the study, it was found that significant predictors were function at baseline, emotional distress, for example, levels of depression and anxiety, and cognitive behavioral factors, both positive and negative. So this was, for example, pain catastrophizing, but also self-efficacy and fear avoidance beliefs, etc. So as a summary so far, there is a marked co-occurrence between chronic pain and emotional disorders, which is difficult to address in treatment. And generally, treatments are not effective enough for these patients. Even though we see some effects, they still have severe problems. And this includes monodisciplinary as well as multidisciplinary treatment. Includes also treatments informed by psychology, such as cognitive behavioral treatments. And what is clear from these clinical pictures, right, is that the problems stretch beyond chronic pain. And it might be that emotions and emotional problems also affects treatment engagement and affect treatment outcomes. For example, we saw that these factors predict physical functioning and affect functioning in terms of outcome. And it might also be that the emotional problems are not as affected by the current therapy. So we'll get back to that, but another message along the line here that I would like to convey to you is that emotions are intrinsically related to the pain experience. This might affect how we understand the similarities between pain and negative emotions, and I will show you some examples here. So symptoms of low mood, lack of interest, pleasure, worry are part and parcel of experiencing chronic pain. What we see here is findings from a meta-ethnography. That is a study pulling together qualitative reviews on what it's like to live with chronic pain, and then synthesizing these reviews. So in the study was in total 187 studies covered with over 5,000 participants. And what I think what is clear in this result is that the lived experience, or the phenomenology of living with chronic pain, integrates pain and emotion. So these pain and emotion are experientially fully integrated. People report not only about the sensation of pain, but about the lived experience, which includes struggling, the sense of self, the struggle to be believed, etc. So still at this study and on the phenomenology of living with chronic pain, this contextualization of living with pain problems has many and important emotional layers, which also includes social aspects. The chronic pain affects the social aspects of daily life and identity and emotions. And we can see some examples here in these quotations about my relationships, people highlighting how it impacts my relationships, my role in the family, identity, the experience of people no longer believing in me. So emotions are related to the pain experience and also socially contextualized. And about emotions, one perspective in this is that we can understand emotions as essential and ancient biological and motivational systems with survival value. So emotions have large impact on our behavior and our motivation and guide us towards our goals or away from threats. And as described by Gilbert, one can identify or see it as we have different emotion regulation systems that interact together. Those that are focused on threat and self-protection, those that are focused on doing and achieving, and those that are focused on contentment and feeling safe, as illustrated here. And I think the message here, why I bring this up, is that threat processing cannot be understood if we conceptualize this from an emotional theory perspective. Threat processing cannot be understood in single domains of cognitive, behavioral, physiological aspects, but rather it's a complex multimodal brain state when the organism processes a threat. And often threat processing cannot be focused only on single emotions, for example, anxiety or specific fears, but often a combination or conflicts of emotions. And also that threat emotions can have both conscious and non-conscious attributes. And what has been described in the literature, and what when depressed state and chronic pain states are described and conceptualized according to these emotion regulation theories, it can be understood that all of these systems are affected, intertwined in the reflecting the lived experience of chronic pain or depression. So both the impact on the doing achieving component, the experience of no longer being able to do what I did before, limitations in daily life, feelings of despair, and also as we saw in the previous slides, the social aspects, the experience of being alone, being disconnected, feelings of unsafeness, and experience that no one really understands me, and I'm separated from my previous context. And of course, in terms of the threat and the self-protection systems, they map to the experience of anxiety, fears, but also this frustration or experience of being trapped. So kind of that all these experiences are in the picture. So this was to bring us forward, or to have in mind in terms of understanding the comorbidity of pain and emotional problems, and also how this maybe can inform us. So the take here is it so on this comorbidity? How may an integrated way help us move forward? Is it so that an integrated understanding of these problems could be beneficial for our patients, for our treatments? And using the word comorbidity, of course, it's of interest to see what do we mean by comorbidity. What is that? Because in one sense, the definition of comorbidity is that it's a disease or condition that coexist together, but could be seen as independent of another. So we have one disease or condition coexisting, but more or less independently of another. That's one view of comorbidity. They are thought to be different or coexisting. And then people ask the question of, for example, which conditions is the primary or the principal diagnosis, and which one is the secondary, and also different ways these comorbidities could be explained. For example, if one causes the other, for example, is it so that the anxiety disorder causes pain, or vice versa, or if they influence one another in some mutually maintaining way. For example, that pain gives anxiety problems, and anxiety problems increase the pain, that these relations are bidirectional. And another assumption could be that there's some third factor, for example, a common predisposition, shared event or vulnerability, which increases the likelihood for both these problems. Or, of course, that they could be completely independent, just caused by factors not related to each other. So as you hear, this could be really, different angles to this complexity. And the transdiagnostic view on comorbidity would focus on commonalities rather than differences between the two conditions, and exploring underlying shared mechanisms. So that's what we are going forward in here. So focusing on similarities between pain and negative emotion. As mentioned, they are both biological and motivational systems with similar function, with the function to protect against harm and threat. They are both profoundly contextualized, social experienced, embodied, embedded experiences. And the question maybe not so much why they occur, but why they get dysregulated. As illustrated here, where we would expect pain and negative emotions as a natural response to, or might increase high as a response to different stimuli, but then we expect a decrease over time, right? But for some, these high levels are maintained, which might be understood as a problem of dysregulation. So one way to understand this co-occurrence between pain and emotional problems is by taking a transdiagnostic perspective. And the idea here is that shared behavioral and cognitive processes can maintain and contribute to the exacerbation of these observed comorbidities to both of them. And so with respect to chronic pain and anxiety and depressive disorders, this means that instead of one being a consequence of the other, or both being caused by a third variable, the co-occurrence is best explained by the overactivation of basic emotional regulatory processes, these emotional regulatory processes have an impact on both conditions, both the pain problems and emotional problems. And by emotion regulatory processes, I here mean worry, rumination, emotional suppression, avoidance behaviors. So in other words, that pain and emotional problems may share underlying cognitive and behavioral mechanisms that function to regulate emotions evoked by these uncomfortable states. So while in essence normal and adaptive, these regulatory strategies may be overly relied on and lead to worsening of the condition. And of course, there may be, or we know that there are other shared factors that play a role in both conditions, such as shared vulnerability, for example, making individuals more susceptible to the underlying mechanisms. But taking departure from this transdiagnostic perspective, a transdiagnostic treatment would focus on emotion regulation, which, according to these hypotheses, may improve outcomes for both conditions. And then the question is how this could be done. This is just another illustration. Is it that worry, rumination, catastrophizing, avoidance, etc. play an important role in this dysregulation? So a transdiagnostic perspective implies understanding and treating pain and emotional pain problems in an integrated way. So how may we improve treatment for this patient group? So I will now describe the hybrid treatment as a treatment model and our findings from those, from evaluating this. But just first, as point of departure here, we all agree that we want to move or facilitate a transition from the patient's current state with pain interference, emotional distress, to recovery, right? The question is how, and again, the processes to target. And as many of you or all of you know, in this field of research, now taking more historical perspective, right? In this field of research, the fear avoidance model has had major impact. The model describes the mechanisms underlying the development of chronic pain and disability. And there is solid support that the basic tenets of this model, that is the associations between pain-related fear and disability, and the role of fear learning and avoidance, that it's had an impact on the development of chronic pain problems. And the clinical translation of the fear avoidance model has then been to develop exposure treatments, as you all also know, to help patients move from avoidance to approaching daily life activities, to challenge fear beliefs, to promote the learning of new associations. So exposure consists of behavioral testing, movement and activities, where the key part is to look for and create opportunities and conditions that may violate the patient's negative and maybe catastrophic expectations and set the stage for new learning. And of course, this is best done or aiming for not only jumping off a chair in a controlled environment or lifting buckets, but mostly focusing on valued and important life goals. What is it that this person wants to be able to do again? And again, just an historical review or perspective, there has been considerable amount of studies on the efficacy and effectiveness of cognitive behavioral therapy focused on exposure during the past 20 years, about 20 years. Many single case studies, several RCTs, studies on outcomes, moderators, mediators, different pain conditions, back pain, whiplash, fibromyalgia, different populations and settings, primary care, specialist care, youth, working context, and also different targets or methods for the exposure treatment, more or less formalized behavior experiments, in vivo, interoceptive, etc. And one can think then that we already know what we need to know about this. We already have developed this effective treatment. Is it all good? And I think we can agree that still, despite these decades of research, it's not all good. Cognitive behavioral therapy does not work as well with comorbid problems. It's not that exposure does not work for the pain problems, but it seems not to work as well when there is also emotional comorbidity. We also have, several experiences and reports on challenges in implementing this method into clinical care. Differences, it's also interesting, I think, the difference in the phenomenological experience, which creates a challenge for engagement and alliance. For example, we as clinicians, as researchers, may theoretically use labels, concepts such as pain catastrophizing fear, right? As I have done in this presentation. But while patients rather experience distress, worry maybe, or that these behaviors, their activities is not due to fear, due to avoidance, but rather an experience. This is what I need to do. This is how I get through my day. I think this, I don't feel well. So while we think about the problems in terms of avoidance, patients may rather experience the it in terms of protecting themselves from further injury or protecting oneself from more pain or distressing events. And this is a challenge for clinicians to bridge this gap and move forward into the treatment while validating the patient's experience. And another important question, I think, is whether exposure for pain-related fear is enough. Is it enough to focus on the pain problems, the pain-related fear, the pain-related avoidance? Because this subgroup of chronic pain patients that suffer from comorbid emotional problems that I target in this presentation, exposing for pain-related fear and avoidance may not solve all the patient's problems. And emotional problems may also interfere in the treatment, decreasing the opportunities for successful exposure sessions. And actually, this has also been discovered and showed in data, this possible impact from emotional problems on the exposure efficacy. So first, we know from previous studies that there's a great variability in treatment results from cognitive behavioral exposure therapy. Treatment effects are not systematic or the same across patients. In fact, one can see substantial individual differences in how well the patients respond to treatment. Just as an example, here you see data from 2 participants, one showing a remarkable decrease of fear and avoidance, whereas for the other one, no improvement is seen. And this study shown in this picture is also from the sham group, where they were using data from a randomized controlled trial, which evaluated exposure therapy for people with chronic pain. This was in a working context, and it was like, on the aggregate or the average on the group level, the treatment was effective, but it was observed that there was a large variation in effect. So why was that? And when analyzing the characteristics of participants, it was found that levels of catastrophizing moderated the treatment effects. And a little bit paradoxically, or maybe unexpected, it turned out that those with low levels of catastrophizing responded well to the treatment, whereas those who scored high on pain catastrophizing did not improve at all from the treatment. So that is, this exposure treatment did well fit for those with pain and low levels of negative emotions, but not for those with a higher burden. So very good effect for lower catastrophizers, but no effect for high level. And the message here is that that the presence of emotional problems seem to influence treatment outcomes. So this was the background. Now we are at the point of the hybrid treatment. So this was the background for the current treatment approach as described in the hybrid treatment. So here the hypotheses are that as mentioned, emotional distress may interfere with the effect of exposure and other efforts to increase function. Emotional dysregulation may need more specific attention, for example, through validation and skills training. Exposure may need to be broader, as patients, not only targeting pain problems, as patients have a range of other problems in their lives. For example, it could target activities, but also emotions and other avoided stimuli. So this pointed the sham group into the direction of a so-called next generation of cognitive behavior therapy, with more flexibility and more focused on the underlying mechanisms, also seeking how to engage these patients in treatment. So this is the treatment I have been referring to as the hybrid treatment. Hybrid here refers to to the combination of exposure and emotion-focused treatment. It's based on the fear avoidance model, but extended in focus. So taking this transdiagnostic perspective on pain and emotional problems. So compared to traditional exposure protocols, treatment manuals, the differences are first that this treatment includes a more extensive preparatory phase for patients to get ready and get the skills needed to manage the exposure part. So that is focusing on emotion regulation, which might be specifically important for patients with high levels of negative emotions. And second, the target of exposure treatment is broadened. So emotion regulation is a key concept here, to train the ability to disengage from unhelpful strategies in a flexible and context-sensitive way. And yeah, this was just an overview of the the intervention content. I think I will move forward here. And I just wanted to get back to this from a more conceptual perspective. I showed you these pictures earlier about the 3 models or emotion regulation systems and these core facets of emotions and how they can be affected in chronic pain and negative emotions. And conceptually, one can understand therapy as aiming for recovery by affecting all these states, right? If you look upon it, a core concept of the treatment is exposure for feared situations, aiming to learn new and safe associations. But from an emotion regulation perspective, we can see that all of these emotional states are addressed in the treatment, engaging in activities in daily life, decreasing fear, and also the connectedness and the social aspects. And that's actually also maybe a difference in this treatment based on earlier exposure treatments that here as illustrated in the later phases of the treatment to explicitly target social relationships and needs and skills training in the social context. First, now to the data and the results. First, the intervention was evaluated in a randomized controlled trial compared to internet-delivered cognitive behavioral therapy. And it was found that this approach particularly lowered patients' the pain interference level and depression levels. It also had an impact on pain catastrophizing, lower levels of pain catastrophizing. So patients felt less helpless and worried. The participants in this study, they had comorbid problems, and about 40% fulfilled criteria for major depressive disorders. About 50% fulfilled criteria for anxiety disorder, and about 30% had both depressive and anxiety disorder, and of course all had chronic pain problems. And in a follow-up study, it was found that the proposed mechanisms, pain-related and emotional dysregulation, was affected and seemed to mediate the effects on pain interference and depression. Sorry. So changes in depression was explained by this by the effect of pain-related and emotion regulation abilities. So first conclusion was that it could be considered an acceptable treatment option for patients with chronic pain and emotional problems. And our latest project, this is the one that I have been working with during the last years, has the main research question of if the treatment has been successfully, how could a treatment be successfully implemented within the healthcare system? What are the effects when psychologists deliver the treatment in their own healthcare contexts? Primary care, specialized care. And again, we targeted patients with comorbidity and an impact of pain problems on their daily life. And this was a large-scale single-case experimental design study with 31 participants. First, psychologists were trained and recruited as clinicians in the study, and in total 31 participants provided complete data. And as you see here, it was quite an even distribution between primary care and specialized care among these patients. And again, it seemed that we managed to target the group that we intended to, patients with chronic pain and comorbid emotional problems. So in this study, almost 60% fulfilled criteria for either diagnostic criteria for either major depressive disorder or anxiety disorder, and 36% had both these disorders. We can also see that the level of healthcare use was high. 26 participants had more than 10 visits to a physician during the previous 6 months. In this study, we evaluated effect from the repeated measures. So we had weekly data collection on depressive symptoms, anxiety, pain interference, and also worry, avoidance, and catastrophizing. And when aggregated across participants, it was a significant treatment effect only for one of the pain interference outcomes. However, when we go to the individual level, and this is the, as I see, the strength with the single case experimental design that is based on solid evaluation on the individual level. And when we look on the individual level, we can see that not all participants had effect, and not all had a large effect, but about half responded with at least moderate treatment response on at least 3 outcome measures, and 32%, 10 participants, were classified as having a robust treatment response. And interestingly, I think this is very interesting, is that when we looked on implementation of the treatment manual, we could see that, and we did this form of sensitivity analysis. We looked how was it for those that we classified as having a solid treatment response, these 10 participants, compared to those with either no response or a weak treatment response. And we can see that like mostly participants had more or less the same number of treatment sessions, but it seems that it was a challenge to implement the key elements of the treatment, namely the exposure treatment. For those with a solid treatment response, these patients also had completed the full manual, the treatment manual. They had conducted all steps. Whereas among the other group, we can see a lower implementation rate of these key components in the treatment. About half of the participants did not reach the exposure part of the treatment. So summary, participants with a positive treatment effect also carried out according to plan to a greater extent. So there seems to have been challenges going through the treatment despite efforts to provide this preparatory phase and engagement. So conclusions on this part is that the hybrid treatment could be implemented in primary care and specialist care with positive clinically relevant effects for about 1/3. And that treatment effects appear to be related to the implementation of the intervention, specifically these key treatment elements. And very, very briefly, I will just mention to you that we also conducted a qualitative study investigating the therapists' experiences. And this was based on the consolidated framework for implementation research. And in line with previous research, participants, the therapists highlighted importance of leadership for their ability to do this treatment in their clinical context, difficulties in terms of prioritization, and the patient flow, etc., and the need for support in their organization. So these are just a picture of how we identified promoting and hindering factors according to different implementation aspects. But what I want to highlight here is that what was maybe the most, to say, finding that was specific to the hybrid treatment is the perception of how much the treatment could be adapted to the patient needs, that these perceptions differed among therapists. So while the core idea of the hybrid is adaptability and flexibility, the treatment manual is very flexible. The fact that the freedom to choose may suit a number of therapists, but be less suitable for others who would prefer clear guidance and rules on how to work with these patients, and might find it harder to work principle-based. So this was something that we really learned from these qualitative data. So lessons learned, implementation is hard, need to keep people with a clear mandate. Training, this is something we learned, that we need to incorporate in the training how the intervention could be adapted according to context. And also that there's so many other factors, of course, influencing the implementation process, from triaging patients and knowledge within the organization. So I will take time now for questions. This was all. Thank you.
Yeah.
Yes,
Thank you.
sorry, I was just trying to bring you so that I see you on my screen. I can show the slides again, but I was also thinking that we might see each other instead.
Yeah. Thank you, Hedvig. Thank you so much for the very insightful presentation. And we now have some time for the questions from the audience. And if someone has a question, please unmute yourself and speak to. And if you are comfortable, maybe open the camera so we can see you. And you can also post your question in the chat function. Yeah. Or maybe let me kick things off with a question, whilst others can have more time to think a bit further on some questions. I was wondering, in your slides, there is for the implementation. I was very interested in what is the key clinical challenge in the clinic, in a physiotherapy clinic, to manage the patients with comorbid chronic pain and depression, compared to those with only chronic pain?
With only chronic pain, yeah, that's a very good question, and I would say it's kind of many layers to those challenges. One first challenge is to identify these patients and to that they get to the right person in the right time. And this was also a challenge in this study, that because we had these trained psychologists working in primary care, and the patients were not referred to the psychologists initially. So this very much depended on different routines at different care clinics. But in some instances, they had to work on, inventing new routines for these patients to even see a psychologist in this. So maybe the patients were, seeking a physician, and maybe it was the nurses who knew which patients who were in high need and seeking healthcare a lot, or maybe they were seeing a physiotherapist, but had not the patients themselves, and no one else had really thought about the opportunity to also involve a psychologist. So that's one thing, and then of course another thing is what the therapist mentioned when we asked them, that it was challenging to because we aimed here to target for the psychologist to kind of treat the full clinical picture, right? To target all their problems, the pain problems and their emotional problems, and depression, anxiety. But this was, of course, also perceived difficult by some therapists in terms of, how fast to move forward, how to prioritize, etc.
Yeah. I can also imagine, when a patient go to the clinic and they find there is without the psychologist support and only, physiotherapy or other, the clinical care providers. Yeah. Let me see. There are some questions in the chat in the chat, and from Manon. Manon asked it, as primary care providers, how can we effectively identify when a referral to a mental health professional is appropriate while continuing to treat patients such as those with comorbid depression and chronic pain?
And are there guidelines on like when to continue seeing a physiotherapist and when to also see a psychologist? And I think this is also very, contextually depending on different countries, different healthcare systems. At least in Sweden, there is quite a large movement, so to say, to provide more healthcare in also psychological treatment in primary care. As compared to earlier when you were referred to, somewhere else to specialized care if you were to see a psychologist. But now there are more psychologists employed in primary care, and I think that might in the future, help us to have easier access and guidelines. And I think from this study, I also now highlighted the difficulties, but we also have, the good examples. And I think we should maybe look more into those and learn from those. For example, care units where they had routines for collaborations and reporting patients between different healthcare professionals. In those care clinics, it seems less of a difficulty to target these patients. And also, I didn't mention it, but we also in this study we allowed for ongoing physiotherapy treatment during the psychological treatment, and also for the psychologist to cooperate with the physiotherapist. So some of these patients had parts of the exposure treatment, for example, was conducted in cooperation with a physiotherapist. So I think that's also something that we should, look more into and develop.
Thank you. And Fiona, up her hand. Maybe we can leave the floor to her.
Thank you. Hedvig, thank you very much for the lecture. Were there any psychologists whom it was like their first time treating like pain patients?
Yes.
In primary care, thinking.
Yeah.
So there weren't
it was
many.
So I think that
feels like many psychologists aren't used to it, or they're like, oh, pain person. That's just the body. Yeah.
Exactly. Unfortunately, that is my experience as well. Of course, we have a bunch of psychologists highly, dedicated to somatic health and to pain problems. But I also meet psychologists during training, who like they don't know much about these patients, and also have some, own anxiety or thoughts about could I treat a patient with pain, etc. And again, I think there that the cooperation and the need that the psychologist is also, integrated in a multidisciplinary care context, and of course need to learn about pain. But yes, I think that was also, one thing that could explain the findings from the interviews with the therapists, that where some reported that they felt very confident in seeing these patients, and they really appreciated the flexible manual, etc. It was all good, and some felt less confident, and of course it could be related to previous experience. So I think we need to, when we aim for improved pain care and knowledge among healthcare professionals meeting patients with pain, I think we should think that knowledge about pain is not only that physiotherapists and nurses and doctors need to learn about the psychological aspects, it's also that psychologists need to be trained in pain.
Yeah, definitely. Do you know if there's any kartläggning
assessment? Yeah.
Yeah, like how much psychology students get to learn about it in their programs. 'Cause I know that at Karolinska in Stockholm they have quite a lot, like neurophysiology and pain. But that's I don't think that's the same.
I will have to look into that, since I'm also now training as a psychologist. So, yeah. Christian, or sorry.
Yes, thank you, Hedvig, for the presentation. I just wonder, the outcome of the treatment, do you know if that was in any way related to how long they have had pain, or how long they had anxiety or depressive symptoms?
We looked, thank you. It's a very good question. And we looked into that, and, we looked into all. Of course, now you need to keep in mind it's a very small sample, but we still checked it. But all pain characteristics, like no relationship, rather if in any direction, it was that those with the most severe problems, both in terms of pain interference and depression and anxiety, had treatment effect. So really a little bit in line with the previous research that we should not withhold treatment for those with severe problems, but rather they could really benefit. But no patient characteristics, and luckily not, it wasn't therapist effects either. We had 12 or 15 therapists, and so it was no effect of specialized care or primary care, that all in specialized care had effect and not in primary care, and there was no effect of therapy. So among the therapists, the same therapist could have some patients with good treatment effect and some patients not, and that was good to see, as I see it, that it was not that was not dependent on single therapist, but rather that because I find the association between, if you went through the full treatment, so to say, and specifically the exposure part, the association between that and treatment response, I find that very intriguing. And it's also, it's not as simple that the therapist did not provide it. It's rather, the interaction between therapist and patient, and maybe what different difficulties that came up during treatment, and difficulties in moving forward, and maybe taking one step back, and so that's something I would like to look into more. How to understand this, what happens during treatment, and how can we learn more about moving through treatment.
Well, Yeah, and well, I think we have come to the end of today's masterclass. And thank you, Hedvig. Yeah, thank you for your very detailed answer information. And I want to also thank you for spending your time with us to sharing your knowledge and expertise. Also, thank you for allowing us to record today's session, and that will allow others in our network to benefit from your presentation today. And thanks again for everyone joined us today. Thank you. Hope you enjoy the rest of your day. See you next time. Bye.
Bye-bye.
Thank you very much.
Thank you.
Bye.